Okay, good morning, everybody. And first of all, I must thanks for Mina Zainor and Pakistan to invite me here. And I can notice that there is much progressing. Everything's quite good in Pakistan. Okay, so for the following 15 minutes, I will talk on Falcotentorial Dural Arturo Venus Fistula. First of all, I'm sorry. So first of all, do you have, okay. Okay, I will say about the anatomy first. So for falcotentorial region, so we can roughly differentiate into midline and lateral. So midline, as you know, right? So midline, so it including the calcula tentorial cerebelli, and you can see that in lateral aspect, it is the touching around the petus apex of the tentorial. Okay, so the shunt can occur in midline or in lateral view. And so let me briefly introduce you about the anatomy and embryology. So you know that this is a dura, right? Dura, there are two layers of dura, right? The outer that close to the membranous, that close to the skull. The skull is membranous or cartilaginous bone. So this, we call it periosteal dura. And the inner side of the dura that close to the brain, we call it dura propria. So how important, how do you know that it is a dura propria or periosteal dura? The important is that dura propria and periosteal dura, it's derived from different embryology, from embryology. Dura propria, they derive from neural crest. That is similar to the intracranial or brain. But osteodura, that derive from mesoderm. And if you notice from, this is like the coronal section of the brain, right? You may notice that in the outer, it is dura propria. And so for here, just right here, the supraoccipital sinus, some kind of the supraoccipital sinus or transverse sinus, one side, it is the membrane, one side is the osteodura, and the other side is the dura propria, right? Whereas, as you can see that, it is a falx cerebri inferior occipital sinus, supraepitarsal sinus, right? Are composed of only dura propria only. Why is this important? As I told you before, right, that dura propria is derived from neural crest. So it means that once that dural shunt occur there, they usually have the direct, retrograde venous drainage into the leptomeningeal collateral or into the leptomeningeal venous system. So that is mean if the shunt occur here, right, at the falx cerebri, tentorial cerebelli, and also at the spinal level. So it almost always have the cortical reflux, or it means that it is aggressive. So it is corresponding to the group that study from Pierre Lajeunesse that I hope that you ever seen this diagram, right? So from Pierre Lajeunesse group, they differentiate into three types of the dural shunt according to the embryology, right? So the thing that I mean, this corresponds to the lateral epidural shunt that corresponds to the green line here. So on the paper or on their notification, they say that all here that occur according to the lateral epidural shunt, it almost always have the cortical reflux, or meaning this is malignant, and most of them are male predominant. So this is correlated with us. So all of falcotentorial shunt is corresponding to here by the embryology. And for the venous drainage, right, the lateral group that occurred just close to the and around this area, right? So it's drained into the supratentorial drainage, into into the lateral and inferior surface of temporal and occipital lobe. Whereas in the middle group, the shunt will drain into the auricular or transverse sinus to a sinus vein of Galen, or also have the infratentorial venous drainage. And if they occur around the free edge of tentorial, they almost drain into the basilar and lateral mesencephalic vein or even spinal vein. So this is the example of the lateral location of the shunt. You can see here, right, that the shunt is here there in the lateral location of the falcotentorial location, and all the veins that number one is all retrograde venous reflux with the supratentorial drainage, as you can see. And here in middle location, right, the shunt maybe occur at the auricular, straight sinus, or vein of Galen. And after that, it have the cortical reflux into the deep venous structure, as you can see. And one thing that you need to know, it is the arterial supply, right? As you know that most of the shunt is in midline, so the supply can come from bilateral carotids, blah, blah, blah. And one artery that you should know is called the artery of the Widorf-Eschscheder. So this artery, they said that, it is the dural artery that arising from the posterior cerebral artery. And it, just go down beneath the tin and surrounding around the brainstem, and is supplied in the midline of the tentorial cerebri here. Okay, so this is one of the artery that come from the posterior cerebral artery, and is supplied to this kind of shunt. And remember, it is the dural supply. This is not the pile supply here. This also demonstrates the red line of the course of the artery of the Widorf-Eschscheder. So another shunt, right, that I said before, that a shunt that occurring along the free edge of tentorial here, as the marker you can see, right? So it's a drainage driven into the basilar vena plexus, and finally drain into the lateral pyramidal mesencephalic vein like this. Okay, so I can go for the example of the case. So this case came in. Please notice this is female. This is female. Came in because of acute hemorrhage. You can see at the cerebellum, and from the contrast CT, you can see the significance of dilatation of the cortical reflux at the posterior fossa, right? And we do the angiogram. This is the injection from the left ECA, and you can see that, right? The supply go to here, right? So the shunt, it is in midline. Okay, and so it's just about the proximal of the straight sinus, and then reflux into the vein of Galen. This is from the right side. Okay, the venous reflux like this, and also similar venous drainage from the right side like this, and also from the branch or from the posterior meningeal branch of the vertebral artery that came to the same location with same of venous drainage, and caused the significant venous congestion of the posterior fossa, you can see. Okay, so although it is falcotentorial, but the concept of treatment of dural shunt, as you know, right, that is the same, that we should cross at the venous outlet, right? Or if you can close, if it depends. If you can close the artery or vein, it doesn't matter. Any access that you can go, but you have to know that you have to cross at the foot of the vein, right? So because you can see that there's so many supplies from bilateral side, and they're too small to navigate into that. So we usually try first with the transvenous approach, and we successful to that. We pass to the synaptic point and to the shunt, and then you compare between you can see that here the location of the shunt, right? And we can go. This is the microcatheter transvenous. We can go up there and showing the same venous drainage. So after we go there, so we're happy, right? Just put, any cord. We use the fiber cord at that time because it's cheaper. Yeah? And after just only cord, after simple pushing the cord inside and all gone. Okay, and clinical improvement, you can see that the go back of the vein, relief of the venous reflux. Okay, so this case that healed by only first time by using the retrograde transvenous coiling. Another case, this case is interesting. Female that are known to have hyperthyroidism presenting with tinnitus. Okay, so at first by clinical it looked like it cannot be dural CCF, but it's not. The MR or CT showed we didn't see any cortical reflux that much. Didn't see dilatation of the supraophthalmic vein. But now you see that, right? This is a shunt at the midline of falcotentorial, as you can see. This is from the right side injection from the middle meningeal artery. Okay, but if you go back to here, right? Okay, you see this shunt here. But what is this here? So we bring the angiogram higher, and this is the injection of the same side of the superior artery. So you can notice that there is another shunt, right? That supply from the occipital artery and pass through pass to the bone and got into the cortical vein like this. So there's a two shunt that are marked by red arrow and blue arrow. So we decided to do, right, because both of them are malignant. And again, the same, this is the injection of the carotid artery, similar, that show the same shunt, and the former one, the red one, this is also supplied by the pile, but actually you notice that the vein is the same, and causes significant, congestion, but fortunately, the patient don't have the clinical symptom of the venous congestion. But notice that no filling of the deep venous structure, the stress sinus. Okay, so similar thing on the left side, and here that's a collateral. It means that ipsilateral of the MMA that crossing according to the red arrow, right, to the same vein. After you recognize that, you know that where to close that. So and also, this is the supply from the vertebral artery, and again, please notice, this is the artery of the Vidal scatter that also supply to the middle of the falcotentorial shunt again. So we decide to do both, and we choose the first one, and you can see that it's the most easiest one is go by the middle meningeal artery, right, on the left side, and we got down there, and just not difficult to use. I still using glue at this moment, and after just one shot of injecting this, that the first shunt disappear. So now we plan to do with the second shunt, and it's not difficult, right? Because you can see that the sinus is patent, so it's not difficult to go transvenous, and that notice that the shunt is distal to the stress sinus and close to the vein of Galen. So if you just close at this point, it's going to be okay. Okay, this is our core mesh on the AP and lateral wheel, and again it disappears. And immediately you can see that how the brain appear, okay? And we have the chance to follow up at the 2.5 year, and you can see that all the vein just significant decrease of the dilatation or ectasia, although we didn't see the deep venous system, okay? Another case of this male, 50 years old male, came in again because of acute cerebral hemorrhage and causing obstructive hydrocephalus, because of massive head, you can see, to the fourth ventricle. Okay, after the patient have got the interventricular shunting, so the patient was immediately sent for embolization, and this is from the right ascending pharyngeal artery injection. You can see it, right? So the shunt is somewhere in the venous pouch in the midline of the posterior fossa, right? And drain to the, I think this is the posterior mesenteric lateral mesenteric vein, and then finally empty into the vein of Galen, and finally empty out into the transverse and sigmoid sinus. Similarly, okay, you can see this a lot of supply, from ascending pharyngeal, from the occipital artery on both sides, and on from the posterior meningeal artery of the vertebral artery, okay, which cause significant congestion of the fossa. And here you can see that we didn't see the transverse sinus, and it seems to be that we cannot go by transvenous approach to get into that vein of Galen, right? So in this case, after we try and we fail to navigate through the vein, so we choose transarterial, and we choose the most, easiest one. Remember, this is the one. This is from the ascending pharyngeal artery on the right. So the arrow just mark. The arrow is point out at the tip of the microcatheter. And after that, and we saw this the same thing. So our goal is that we have to occlude here, okay? And this is finally that this is the onyx cast, and you just compare it on the peer view, right? The conic cast, that's similar to this one, okay? And after just only one injection, everything's gone, and the congestion is look much better. And probably this is my last, not last case. Another case, the patient came in, this is male again, came in because of like a venous thrombosis or venous congestion of the bilateral thalamus, right? And again, you can see that this is the shunt, okay, here at the mid of the straight sinus with the complete occlusion of the proximal of the straight sinus, and retrograde drainage into vein of Galen and the other. Okay, and supply again from everywhere, as you can see. So in this case, we success to navigate and to pass to this the stenotic or the occlusion point until go there. And after that, we found happy and it's easy that to put a coil. I don't know that you have or not, but this is one of my favorite that to use the fiber coil. It's a fiber coil, and it's much cheaper. It's much cheaper. And after this, there's a few coil and everything gone. Okay, and this is the last case, male again. The patient came in because of headache and meningism, and you can notice that there's a hemorrhage at the right side of the medial of the thalamus. And then we bring the patient for angiogram again. Okay, you can notice here the shunt is just at the vein of Galen. Okay, supply from everywhere. So we go again, not that difficult, right? To get transvenous into the vein of Galen. But during COI, maybe this is the old case at that time, we didn't pack good enough at the point of the vein of Galen. And you can notice that on follow-up, the shunt is still there. There's still some residue of the shunt, okay, with the cultural reflux also. So again, this is not that difficult for us to go transvenous again, and because you already have the coil inside. So after you place the microcatheter, you just inject onyx inside the coil mesh, and just easy, and everything's gone. Okay, so lovely, I would say that. Focal-to-the-dural shunt are rather rare, infrequent, however. It always aggressive, remember, because of their nature embryology of the dura propria, right? And almost always have the direct cortical venous reflux. And on middle location, the torcular straight sinus or vein of Galen is more common as compared to the shunt at the lateral side of the focal-to-the-dural lesion. And just in our experience, we found a few cases that corresponding with the multiple dural shunt, and also found in the female group. So endovascular treatment is successful, and I think it's 100% that we can cure by using transarterial or transvenous. It depends on the anatomy and the things that you think. And finally, I just say that, so if we fail to reach the shunt maybe radiosurgery can be benefit, but I don't have that experience. Okay, thank you for your attention.